Hey, this is Ash from All Things Dentistry. Ever want to know the secrets that endodontists use to get down complicated canals? Well, look no further. Check us out at allthingsendo.ca where you'll find those secrets to unlocking your endo potential. Dentistry, the place where we're passionate about sharing those unwritten hints and tips of dentistry. Well, today I got one. Today. It was a few days ago, a few months ago. And what am I talking about getting what? Well, it's a Radix. So what am I looking at? I'm actually looking, I remember when I got this radiograph, I'm like, yes! Not so much that the tooth has a painful tooth, the patient has a painful tooth, not that we have this extra little root. You can see it right there. So this is a clinical exam. We'll just follow through it. We're going to take a shift shot, and we're going to try to figure out what side of the tooth this is on, because it's a spare little root. And what we're looking at here is we've got, occlusal restoration, and when we have a open pulp chamber essentially, and if we follow the PDL all the way around, we've got, solid PDL. No type of like endodontic lesion whatsoever. And then actually when we do a percussion test, it was just normal apical tissues. But interesting, she had cold sensitivity. So it's kind of hit or miss, like, I don't know if in your own experience, you put in the comments below. Some people she had really painful lingering sensation to cold, but then she did not have any percussion sensitivity. I mean, what does that tell me? It tells me the inflammation has not progressed to the PDL, but it's just interesting. So she definitely had cold sensitivity, and then out comes her diagnosis, was tooth number 47, symptomatic irreversible pulpitis with normal apical tissue. So what we're going to do now is we're going to provide solid anesthesia, and I need to shout out to this comment, and I'm so grateful for changing my regime for the last couple months, not this case, but regimen in terms of using articaine as a block. My blocks have been solid. All right, so let's get started. So we've got a rubber dam on. We've made sure that the patient is completely numb by checking with cold. So we've anesthetized her. Then we've tested with cold test to make sure that at least, one of the things we could replicate during our clinical exam was cold sensation. So we've gotten rid of that. We've numbed her up. Next test I'm going to do is I'm going to just check to see if she feels any pain when I touch the tooth with a burr. So this is a number 4 long round shank burr. And the reason why I'm using the long shank is so I can keep the head of the handpiece out of the way. But the problem in this situation is that the handpiece is actually in the way because it's a tooth number 47, a little more difficult access. So you can see the access angulation. It looks like I'm going towards, outside the mandible. But what happens is I'm going to straighten up the handpiece and I'm asking her, do you feel any pain? You saw that little wiggle there. So what we're doing is we're going straight into that, slowly into that tooth. And, our access, if we take a look here, we'll talk about the SLOB rule in a second. Our chamber is fairly wide open. So I'm not, I am actually kind of expecting a bit of a drop. So the beauty of using a long shank burr is that what I'm doing is according to Deutsche Musikkant in 2002 or 2004, it's so helpful, is that the change from the tip, the tip of the burr to where the shank changes, from the tip of the burr to where that shank changes right about here is 6 millimeters. So based on their experimentation from the tip of the mesobuccal cusp, if that's it, to the top of the pulp chamber is 6 millimeters on essentially every molar. That at least gives you a start. So what I'm doing here now is I've changed the angulation of the burr. So the burr is a little bit more upright, but it's still kind of angulated, a little more kind of. My burr is angulated lingually because most mandibular teeth are angulated lingually in the mandible. So what we're doing here is I'm just looking to see. You can see the beauty of having a long shank burr is I can actually see what's going on in my mirror. I mean, second molars are difficult to see because access is difficult. You can use smaller mirrors, this number 2 mirror, and you can see we're so close, like right there, so close. So we're gonna go back through, and then we'll pop through. Oh, there was the drop right there. You see that drop? Boom. And that drop correlates likely to this space right there. Like, boom. That's a beautiful feeling, isn't it? Amazing. I love it. So what we're going to do now is you can see the pulp is certainly irritated. And I'm going to use my Endo Z burr, which is a non-cutting tip. If you haven't used one of these, go ahead and get your hands on one of them. The brass, everybody makes a different version. But of course, when I went to use my Endo Z burr, she felt something. So what we're going to do is we're going to use an intrapulpal. So this is a extra short 30 gauge needle, and we're going to place that into the pulp tissue and apply tons of pressure because that's how the intrapulpal works. And the beauty of having a small access is that Well, it's difficult to get that. It can be difficult. This is a little bit larger than I'd like. Usually a number 2 round's even better, but this way I can apply a lot of pressure. Because I don't know if you've done an intrapulpal when the entire pulp chamber is wide open. It's really tough to numb anything up. And with the 30 gauge, I'm trying to get down, if I can, sneak it down one of the canals just into the orifice a little bit. And we're trying to apply pressure because anesthetic needs soft tissue to go from an acid to a base. And there's not enough soft tissue, in my mind, in a pulp chamber to elicit that change. So here we are, we're using our Endo Z burr. Beautiful burr, I love it. The only thing I don't like about it is I can't see what's going on. So I really have to rely on a sort of a tactical feel. What I'm doing is I'm lowering the cusp just a hair. And it allows me to get a really stable reference point. Honestly, this tip has been kind of a game changer. It takes a tooth a little bit out of occlusion. That might decrease kind of postoperative pain. There's an article by Paul Rosenstein. Rosenstein. Anyways, as you can see right there, so that is one of the problems with that burr is that what happens is, let's go right here. Let's take a look. So I used it initially thinking like, oh, sweet, I'm all done. But no, I'm not. What happens is it ramped up kind of where the access was, and it kind of went down here into the mesial portion and then kind of went up like this. So you have to be, just be cautious with it. Because what will happen is if you use it too long and it's super sharp and they're brand new, you may actually increase the amount of tooth structure you remove, and we don't want to do that. So let's go ahead and finish off this access using our Endo Z burr. Lots of water because it keeps the flutes really clean and it's much more efficient. And of course, dang it, she needed another intrapulpal in that distal tissue. And then we're just doing anesthesia here. We're applying lots and lots of pressure. My dental assistant is suctioning all that terrible tasting anesthetic out. And then what we're going to do is, so there we go. And one of the benefits, I know Ali Nassay talks about it, is using an intrapulpal just to, even if the patient is completely numb, especially on these irreversibly inflamed cases, what it does is that the pressure and potentially the epinephrine induce sort of hemostasis. And then you can see what the heck is going on in your pulp chamber versus having this huge hemorrhaging mass. You can't see anything. You're like, oh my gosh, did I perforate? Everyone say aye if they've known that feeling. They haven't perforated, but they're really terrified that they have. Go ahead and put in the comments below. I've been there, done it. So the beauty, because this tooth is hemorrhaging like crazy, and that bit of that intrapulpal is helpful. So what are we looking for? Because this is a radix, right? Well, let's take a look at a shift shot. So if we pull up this guy right here, we're looking for, this is a mesial shift. So remember the SLOB rule? Yeah, that thing. It's super helpful in endo. I don't have a cone beam, and I don't think it's necessary for this case. Unless we had an intraoperative issue, then we would take a cone beam. So if this was the initial radiograph, what I'm trying to figure out is what side is that radix on? Is it the buccal or lingual? So I took a mesial shift. So knowing the same side lingual, opposite side buccal, this root shifted a little bit to the mesial, and it almost looks like like an elephant trunk, if you may, or a 3-legged table now. But now I know it's the same side lingual. So now I'm going to be looking on the distal lingual for this canal. Now, a cone beam would be very helpful in this case to know how curvy it is when it comes out of pulp chamber. So we're actually going to test that using our Wave on Gold. We're going to do a tactile sense. You'll see what I mean. So what we're going to do here is I'm looking right there. That's where it is right there. That's you. That's you, Mr. Radix, Mrs. Radix. All right, so what we're going to do now is let's just let this play. This is a standard technique I've been doing this for years, and I don't get paid by, if you're wondering, I don't get paid by any of these companies. I use it, Wave on Gold, I use it primary, and I use this file to open up the coronal 2/3. It's an incredible tip that I was taught, and what that does, so I'm opening up the mesial canals, and then I'm going to open up that distal buccal. You see that angulation change right there? This is the benefit of having an access chamber, especially on, Instagram is amazing because you can learn so many things. Facebook's amazing. I mean, here I'm YouTubing. The problem is that my experience has been, especially as a mentor and a teacher, you see amazingly skilled clinicians making these super tiny little accesses. And then when you go to, it's okay for them, but when you go to practice this, especially in a 7, man, it's so hard to do those tiny little accesses, and then it's even harder to get in the canals, especially in a case like this when we're looking for, this radix. So I'm not saying blow your case out. Okay, so here, let's take a look. Where are we at? This is our mesiolingual. I'm just comparing the mirrors. So there's our mesiolingual canal. There's our mesiobuccal. This is our distal buccal right there, and this is where our little friend is, our mesiolingual. And so I'm going to place my OR seal. This is our secondary seal. We place it right before we get cracking. The tip came off again. We just didn't tie it on enough. Anyways, if you're not using a secondary seal, I highly recommend you do. Or seal is great because I'm not getting paid. I'm not even I'm advertising because it keeps our caustic irrigants out of the patient's mouth. And another benefit, as I was reading the MSDS, is that it's gluten-free. So who knew? Who knew you'd need to advertise that on dental things as well? But it's carbimethoxyl. Anyways, it's great stuff. It's super sticky when it's wet. That's where we're wetting it. So I wasn't quite down that distal buccal canal when we saw it before with that coronal shaping the coronal 2/3. What I did there was I looked at the tip of the file. I'm looking at a couple things. I'm looking to see if it's broken. I'm always, every time that file comes out, I think it's really important to make sure it's not fractured. Taking a look, and I'm also looking to see, what's going on. Where is it cutting? Is there debris on it? Is there tissue, whatnot? So the benefits of opening the coronal 2/3, I started doing this about a decade ago. It's a game changer. And the reason why is because, let's go back to this picture right here. It's a game changer. Oh, I'm cheating here. So so you didn't see it here. Don't stop your file in the canal. It's reciprocating, so I have a lot of confidence. Actually, there's a few issues here. What I'm seeing. Go with me here. One, I'm nowhere near the apex, so I know that the tip of that file is not cutting. I'm just kind of getting a sense of what's going on. I'm just like, okay, are we close? And we're not. This is actually a really long root. These are really long. They're like 23 mils. So sometimes when I have, I'll be honest. So sometimes, okay, the cat's out of the bag. So sometimes what happens is when I have a really open canal, this will actually, I can take this right to working length, boom, without small hand. It's unbelievable. No, they're not paying me to say that. That's why I use this file. It can go to, in certain cases, I kind of gauge as how the file is going to length. And this was going pretty smooth. So I'm like, oh, am I close? So I'll take my apex locator and then we'll just attach it to, the file, or we'll attach it to the metal of the handpiece. Everything is kind of connecting. It's all conducting signal. And we're kind of sensing like, oh, okay, are we close? Are we not? And that just gives me a feeling of like, okay, are we close? And we weren't, not even close. So the beauty of doing what I just did, and you'll see it here, is that we remove most of the pulp tissue from the coronal 2/3 of your case. Then you can see what's going on. When you go to place your hand files, then it's like, oh, I can actually, there's the mesial canals, there's the distal canal, boom, we're set. If I were to try to tackle this and try to start finding that radix right away, oh gosh, it'd be like pulp tissue flying. I mean, it'd be all over the walls, because you'd be taking a slow round burr, pulp tissue everywhere. I mean, it's just crazy. So now you can see, look at the benefit of that. Wasn't my idea, I was just taught it. Now I can, the pulp chamber is open, clean, no hemorrhage from the orifices. I can't tell you how, if there's one tip from this video, just do that. So what we're gonna do now is this is a radix. There's this dentin shelf. It's just kind of like, the shelf on MB2s. Kind of reminds me of that. Actually, just as I was looking at that, it's like, oh, it's like an MB2 shelf, but this one's actually easier to get under. So the reason why I'm kind of like, I think that's it, because there's pulp tissue right there. You can see it right there. So, what would you do? Go ahead and put in the comments. I can tell you what I'm going to do. I need to get rid of that. We need to remove that tissue to make our life so much easier to get, if not straight line access, better access. So let's just resituate ourselves. This is our mesiolingual cusp, mesiolingual orifice, distal lingual. So we know that what we're looking at now is actually this right here is right here. And we'll take another shift, or we'll take a look at that shift shot. There it is right there. So you can see so you can see that in that shift, anyways, so this is where the distal lingual canal is. So let's go ahead and let's tackle that. We've got if it's not a straight line access, I don't think it's necessary with our heat treated files. But I can tell you that it's so much easier to get your small hand files in when you have it opened up kind of with a nice, smooth, continuous flow from the occlusal access part. So what I'm going to do here is we're going to use our endo Z burr and to see if we can remove any of that tissue there, that little dentin shelf. Oh, you know what I'm doing? As I was wondering, I'm like, what on earth am I doing with that mirror? You know what it is? When the rubber dam clamp falls forward? That's what I'm doing, is I'm actually pushing this. So we're like, I need 4 hands. Well, I have Justine, who's absolutely amazing. Justine, you're amazing. Love working with you. So I'm pushing the rubber dam clamp back, and she's trying to get her suction in there so I can get my endo Z burr back in there, my handpiece. It's not even about the burr. It's just getting the handpiece back there. So that's what I'm doing right there. So what I'm doing here, right here, at this, see that angulation? So this is all restoration. So the priority of tissue removal when you're doing root canals is carious dentin, carious tooth structure, undermine enamel, restorative material. I mean, honestly, I should have removed all of this restoration to make sure there are no cracks. I'm looking for cracks in the dentin underneath the restoration. And then what I'm doing here is I'm doing what David Clark and John Academy had written a long time ago, and I use that here and there, is I'm beveling the occlusal axis right here on the mesial. I'm not really doing it on the distal. It's kind of more on the mesial, and what that does is it helps me get my files in. Let's see if I'm doing it kind of right here. So that kind of movement there, I'm just beveling this and, you know, making a little angle here, bevel. So when my files come in, my hand files, it's like, you can make that noise too, into the canal, easy. You don't need to bevel everything. It does bring light in. Sometimes I don't bevel, maybe I will. I usually don't bevel the distal part because it's really hard to get my handpiece to angle that way. But it brings a little more light. See that bevel right there? It brings I think it allows a little more light in. I mean, it's not going to harm anybody. It's on restorative material. But I certainly tell you it's easier to get your files in sometimes. And you can see, all right, so there's a Radix. Man, when I saw that, I was so excited. You have no idea. I'm actually smiling right now. I was so excited to get a Radix. I actually have had, I think, 2 Radixes Rad-Eye before, if that's such a word. But I didn't have a video camera. So I really wanted to share this with you. I would consider this a pretty simple case, a pretty simple Radix compared to some of the ones I've seen online. So what I'm doing here is I elected to, let's see, I think I used a small. I don't see it. Yeah, this is a Wave and Gold small, so it's a 2007. So what I'm going to do is I'm going to use my primary. I'm going to open the coronal 2/3, but I'm also judging. What I'm using this right now is kind of tactile sense. I'm judging to see how easily it goes down the canal. I'm also judging to see if it binds. If it binds, it tells me there's a significant curve and I need to step away from this size of file and go with a skinnier file, sort of less taper. But it went to my coronal, it did go to the end of the cutting flutes. I've never mentioned that actually in this whole entire video. So I'm opening the coronal 2/3. Most teeth are roughly 19 to 21 millimeters. I'm opening the coronal 2/3 just to the cutting flutes. That's the quantitative measurement I have. And then what we're going to do is we'll rinse all that out. So it's like, oh, sweet. It's such a great feeling when that file just like drops and you're like, oh, sweet. Life is easy. Life is good. We're going to rinse all that material out. And then what we're going to do is my concern is twofold. One, I don't really have straight line access and I don't want my file to be pushing against a furcation. And I've seen a number of cases where I think what happened was the axis was too small and the file was having pressure because, say, for example, on the mesial, your file comes in like this. So this is the mesiolingual, or yeah, say one of your mesial canals, and your axis came to about here, was super ninja conservative. What happened was, the file comes in at this angle, and it's being pushed into the furcation as it goes down the canal, and there's always a risk of strip perf. So what I'm doing here is I'm actually going to open up to get a little more. Yeah, this is not Instagram sexy at all. But this is, I'm really trying to prevent getting a strip perf and that furcation. Just removing a little more of that little dentin that's over the orifice. Boom. Now what we have is we have straight line access. I'm not concerned with stripping that furcation floor. So let's do this. So you can see kind of the widespread. Buccal, distal buccal, and then there's our distal lingual. Cool, eh? All right, let's get a working length in these teeth. Okay, so we have our straight line access, and what we're going to do now is, and we've opened the coronal 2/3, we're going to get our working length. Now, I've actually watched this about 3 times now. Excuse me. I've watched this about 3 times, and I was like, what on earth is going on? Now I remember. So this is a technique where it's just literally crown down. And what's happening here, this tooth is so long. I think it's around 23, 24 millimeters. And you have to think, like, in the posterior, that's a long tooth, because you got to take instruments a long ways down. You can barely hear that beeping. So I'm barely, not even, I'm like in the middle zone of the apex locator where you really kind of get nothing. So I usually use a 6 file, but for whatever reason I took a number 8, and it kind of gauges, I'm kind of gauging to see, using an 8 file, kind of like how far does it drop? How easy does it drop? Is it difficult to get it down? But I'm certainly not at working length. And then what I'm going to do is I'll open a 10. And what the 10 does is it then gives me a feeling, because I'm also, when I'm watch riding, I'm feeling to see if there's a bite. So when we're checking this working length, I'm not getting any love. Even though I'm super close, it's still not getting within the kind of green zone of where we want the apex locator to be. So rather than battle with small hand files, especially all the way back to the patient's, posterior, what I'm going to do is I'm going to take a 10 file and check all 3 of these canals, all 4, and you can see me struggle there, kind of get an idea of how long they are. And then what I'm going to do is I'm going to take my wave angle small and cut to that length where I know I have a straight glide path. So what that does then is, if we take a look here, it opens up. So I've opened up to say here with my wave angle primary. I can get my 10 file to say maybe here. So, but it's a really long ways to battle with small hand files all the way down here, get a great glide path. But I know I can just essentially almost take my 10 and get to about here. So what I'm going to do now is I'm going to take my wave angle yellow, a small. You could do with the primary as well, but I'll just use the small. It'll get it down to length further, and then I'll tackle working length. So we're going to put that, we went to that length. I did that for all the canals. And then what I did was, then we took a number 8 file right to length. And let me just turn this up so you can hear the beeping in the background. And I'm using a 31 millimeter file. It's so much easier to get a solid working length. So there's my apex locator winding in the background, solid at the apex. And what I'm doing is I'm pushing. So with my left hand, this is my right hand, I'm pushing the file against the tooth, sliding the stop down. And sometimes, you have to finagle this. There we go. I'm happy with that. It's not quite right at where that flat space is, but I'm happy. I'm going to be subtracting a millimeter from that working length as well. And that gives me tolerance. Tolerances. So, watch that. So check this out. Probably in school, I'm not sure what school you went to around the world. Somebody probably told you to bend your files. I don't think it makes a damn difference, but I can tell you, specific curved canals, absolutely. Specific little J-hooks and whatnot. You can check that out at our course. But these banana curves, I don't know. But I know that the banana curve is really useful for when you go to put a file in these types of cases. That curve, actually, what I'm going to do is I'm going to take that curve, I'm going to sneak it around into, I guess, the mesial buccal. Watch that. And then watch my fingers at the top here. So it sneaks it in, and then it turns to the distal. You see so the file is actually turning, let's see, counterclock or clockwise. It sneaks a distal, boom, and down it goes. Super helpful. So if you're having problems getting your file in the distal, posteriorly positioned teeth, use a little curve to get it in there. So you can hear the beeping again. So sneak that in there, watch it one more time. Boom, apex, we're on the money. So, and the thing I need to say is that I haven't done any, like post-production, hand filing, whatnot, just so it makes it look like, I would tell you, I'm not doing anything here. It's just the strategic, slow opening of that canal. And you see, with the curve, it can help you sneak it in. So that was my distal buccal. So when you see the final radiograph, you're going to say it's actually short, but actually, according to my apex locator, I'm right on the money. So I'm going to slide that in. And sometimes you can use, so look at how straight up and down that is. Actually, I saw this when I was looking at this video before. I was like, man, it's really nice because now, had I not removed that dent and ledge, that file would be angling over here. Again, hard, there's always a potential for furcation strip, especially in these types of curved cases, potentially curved. This can be frustrating. I'll be honest, getting that little stopper. What I will do sometimes, I will just use the numbers. There's an article that relates to, you need to be careful of the measurements, this and that, but honestly, 1/10 of a millimeter is not going to it's not going to break the bank. And sometimes I will use the numbers, the little lines, rather than the stopper. I actually learned that from G-Wagon. All right, so without further ado, let's get our 3506 downrange, and we're just going to take that to length. We've got irrigant in the pulp chamber. It acts as a lubricant. It flows down with my file, and then so it lubricates the canal. As I bring it out, all the debris is falling off into the pulp chamber, the irrigant sitting there. So it keeps my file clean. It makes my procedure much more efficient because I'm not continuing to bring the file in and out. So I'm going back down the mesial canals, just reconfirming I'm at length, and then we're going to tackle that mesiolingual. I decided to go to a 3506 just because it was fairly straight up and down. The primary went to length pretty easily. Okay, so let's go ahead and fit our cones. So this is the mesiolingual cusp, lingual cusp. This is the mesiolingual canal. So throughout, when I'm trying my cones in, I'm going to do a little bit of manual dynamic activation as well with my gutta percha point. I find that seems to be the most effective. The endo activator just seems to do nothing. And ultrasonic, passive ultrasonic seems to be doing nothing as well. I don't have the Eddy. I still need to get one of those. So what happened was, as you see this file coming back to length, it shows me that my gutta percha point did not fit to length. So what I'm doing is I'm just going to clean and shape back down to length because some debris may have fallen down during my irrigation. I haven't completed my final irrigation protocol yet. And the reason why is because sometimes I just have to go back and readjust everything. So I'll check my cones, make sure they fit perfectly right to the right length. Then I'll do my final irrigation protocol. I've lost so much time. So if that's another tip you take away from this, don't do your final irrigation, all that stuff, and don't dry your canals until you make sure your cones fit perfectly. So what's happening, and I highly suspect this in 7s, I can't say it happens all the time, but I find that, so you can see all the debris coming out of all of these canals. It's everywhere. But then the question is, does it really matter? If you pack sterile dentin, does it matter? They used to do that. I'm not doing that, but does it really matter? My question. So what I'm doing here is I'm going to fit my cone. I'm going to pump it up a little bit. That's my quick manual dynamic activation. Check my working length, and then I know what the outcome is. We're happy. But what's happening is that these two canals join. I'll let you in on a secret. So what's going to happen is I'm going to fit my mesiobuccal cone, and it's not going to go to length. Now, I already suspect that these are, like, during the procedure, I'm like, 7s, there's a high probability of them joining. So I'll activate a little bit of manual dynamic activation. That was a fairly weak attempt. But you're going to see me come back with my medium file to clean out any more debris because I don't know if they're for sure joining. But put in the comments below what I should have done to check to see if they were confluent. So another thing that I find is that if my points don't fit, well, especially if there's no patency, I find that sometimes my cones will fit short. So what I'm going to do is we're going to that case, the mesiobuccal canal was fitting short. So what we're going to do is we're going to go back to length and we're going to open that back up. Actually, what I am doing is I do suspect that they're joining. I went back down the mesiobuccal, mesiolingual, and I'm going to try to break up that debris that goes back and forth between them. So because it's still a vital case, there is tissue that's going back and forth between these two canals. Let me just pull this up here. You can see here in our working length, our cone fit, these two canals join. So we want to get rid of all that tissue there. Does it really matter that one goes down to the other? That one does not make it all the way down because there's debris? Probably not, but it's probably better to know in advance. So how would you know? Put it in the comments below. All right, so we're going to fit that. We're going to recheck our working length. We're going to fit our mesiobuccal. A little bit of activation. Pretty weak attempt, I must say. You should do it like 10 to 40 times. All right, so we're going to try in our distal buccal. Now, if it's short, you know what I'm going to be doing. And it's on the money. And we're going to check the magical Radix. I guess it's really important to make sure I activate that one. The real question I have, and you can put in the comments below, is does it really matter? These are vital cases. There's no bacteria other than the bacteria I typically taken into the case. Lots of irrigation. This is the key to your success. And the reason why I say that is because this is a vital case. We want to make sure that we get rid of all of that vital tissue. That's super hard to break down. So we're using full strength. Oh, I did pull it off. Look at that. I did use the drain test. Not always super reliable, I can tell you that much, but I used it here because the reason why, so what's happening is I'm draining from, what is this, mesiolingual. I'm watching it drain from the mesiobuccal. Watch the irrigant drain all the way down. Not always reliable because sometimes what happens is there's an isthmus between. These have two separate orifices, two separate portals of exit, but there's an isthmus typically 80 to 100% of the time between the two mesial canals, and they might be draining there, and you're like, oh, I don't need to clean and shape one.
you only clean shape in one, you take your radiograph like, that's just weird because you've missed a canal. Done it. Been there. So I'm hoping that there's another tip. I hope you don't do that. Don't rely on that technique. There are a couple other techniques you can rely on. Go ahead and rely on those. Put them in the comments. All right, so we're just doing lots of irrigation. This is critical. Watch what I'm going to do here. This is time saver tip number 4,000 that we're at right now, if you missed it. If you made it to this point in the video, I'm super grateful as well. What I'm doing here is I'm aspirating my irrigant. So see in my Radix, the Radix Entomolaris canal, there's irrigant here. What I'm going to do is watch the bubbles. I'm suctioning it out. And what that does is it makes it so much faster to place your gutter pressure points, your paper points to length. So rather than wasting 1,000 paper points, you only go through 2 packs. So much faster. All right, so we're just drying the Radix, and we're just drying our distal buccal canal. There are a couple techniques. I'm not sure if you're going to see it. You can use your working length, use your your paper points to reconfirm your working length. So you'll place it to length. Oh, I'm going to do it. I usually do it. Tap on. So what I'm doing there is so literally, I took my cotton forceps, slid them down to my working length, my reference point, and then I'll measure on my measuring stick. There's my Radix. Slide my cotton forceps down to my reference point. Still wet. So you saw how much of that bent. Watch. Useless. So we're going to take another one. Usually what's really helpful is using undersized paper points, like not super undersized, but maybe by one size. Like I'd use primaries. This is the medium gutter pressure points, or paper points. So I'll do that. And then what I'm doing here is I'm just making sure, see there's like a little lip? I'm just making sure there's no pulp tissue there. There's our Radix friend. And then, yeah, so there's no pulp tissue. And then it's time to place our sealer or gutter pressure points, take a cone fit, radiograph. The most important radiograph, maybe not the most important. Okay, so what we're going to do in this case to prevent extrusion, I'm just going to place my cones in. It seems like every situation is a little bit different. Sometimes I'll place sealers, sometimes I won't. Oh, I got to take the hero shot. I forgot. So there's our Radix there. The floor of the pulp chamber, the road map. See the gray? So it goes towards the distal buccal. This comes towards the distal lingual. It's actually pretty helpful. Unfortunately, I've come to the realization, though, is that you need to have high magnification, whether it be 3.5, 4.0 loops to do endo. I've wanted to be able to say you don't need high magnification, but I'll tell you, if you use 2.0s and you're trying to do molars, and then it's really, really hard, because it's really hard to see these subtleties, because I find that as you up your game in endo, it becomes a game of subtleties. All right, so our gutter pressure point does not go all the way down. Like, okay, there's one. That's another test. Oh, there's the other test. So the other test that I normally would do is I'll place a cone in the mesiolingual, put a cone in there, and then I'll take a 15 file. If you put it in the comments, I really appreciate it. I'll take my 15 file and taste it, put it in the mesiobuccal canal, and see if it pierces. That's a normal thing. I don't know why I didn't do it here. Oh, we're obturating the Radix. It's exciting. Do a few little pumps here up and down. And then we're going to do the lonely distal buccal. All those. So that's another tip another technique that I'll do is I'll use the thumb technique just to, this is a lifesaver here. Take your thumb and put it on top of the gutter pressure points, get them out of the way. And then actually what I did do is, you see how this is curved? So I curved it, and it's helpful to get that cone in there, because I have battled with these cones, my friends, many times. Right. Seated. Let's go ahead and take a look at our working length. Working length radiograph. Here's my cone fit, and I'm super happy with the front of this tooth. This distal part I'm not happy with, but I can tell you that you've watched me reconfirm with the apex locator a number of times, so I'm happy with that. It does look short, but let me show you this case. All right, this case, before I get to this is short. This was actually this video, and I finally got the results. So I can't remember when I did this, and I finally got the results after this IND. So this is 28th December 2020, and I really wanted to post this case and go through the walkthrough, but then I looked at the radiographs. I'm like, oh my gosh, is that how short it is? Let's zoom in here. Is that where the is that the is this the portal of exit and I'm that short? Look at the mesials. Look at this. I know that there's a, you've got a slide down of some sealer there, but look at the difference between the radiographic apex and where the tip of the gutta percha is. I'm like, whoa, I can't show that. I got to make sure it's healed. Well, almost a year later, boom. I'm happy to say that by relying on your apex locator, that is where you need to go. So, this might not, obviously this is around the portal of exit, and this, this is not. So whatever this is, it looks like it's a curve, like, whew. And look at the difference from here to here. I mean, it's huge. Let's zoom out here and take a look at it. So, so when I look at these types of cases and I go back to this case, I'm like, you know what, I'm going to leave it because I've reconfirmed like 3 times with my apex locator. I'm happy with it. Okay, so we've gotten our working length radiograph. I'm happy with it. What we're going to do now is we're just going to sear off, because it's in the distal, it's fairly posterior. I'm just going to sear off the tops of the cones. This can be useful, and it doesn't have to be. It can be one or the other. So you can see I put a curve in my heating tip just to be able to access. I'm kind of like brushing the gutta percha away because it's posterior. I'm kind of like, you know what? I don't want to pull that gutta percha point out. I know you have. I know that I have many times, and I'm just trying to kind of like, I feel like I'm pushing the blinds away. Like when you're opening a window and you're kind of like opening it from the middle and the blinds are closed and you kind of slowly open it from the middle. That's kind of how I'm thinking that's what I'm thinking about when I'm doing this type of technique. So I'm just going around the 4 corners of the tooth, kind of around the box of the internal part of the access, just to slowly remove that mass. Sometimes I can see right in there, like if I had better direct line vision, direct access, I'd just, bam, cut them right out, get them right at the orifice there, Bobby, but I didn't. So what we're going to do is we slowly remove the mass of it, as you watched it there. Because I'm using a single cone technique, I've been using this for, I don't know how many years now. I love it. It's not for every single case, but I would say 99% of the time I use it. And because continuous condensation is a difficult technique, thermoplastic backfill downpack shoulder technique is difficult. They're all difficult. Single cone is super predictable, super efficient, and it works. So we're just fiddling around now. And what I need to do is I need to rinse that out or take my... So what you're seeing here is somebody used my plugger as a heat carrier. So that's why it's bent. That's actually a nickel titanium end. So that's what happens when you burn nickel titanium. It bends. And it still works. So we just use it. So we're going to sort of burnish. Ali Nassay calls it burnishing. Kind of burnish the orifice. What I really need to do is rinse all that sealer out of there to see what I'm doing. So I'll use both buttons on the tri-water syringe, and then we'll take a look here and see what's left of our obturation material. You can see the distal. Let's clean all that out. So now you can see what the heck is going on. So we'll clean that out. This seems to be a little bit slower as I'm watching it than usual. Sometimes if the axis is a little bit bigger, you can just cut them right off at the orifice. Like I said, cut them off at the orifice a little bit faster. But I think like if you're just learning root canals, just don't get frustrated, because this is actually a really frustrating part. It's all frustrating, to be honest, but you would think that warming gutta percha and searing it off would be a simple technique. And there was a little bit, oh, that's right, I remember. I took my Muntzburr just to remove, I'd had enough because there was some getting locked into a certain spot. And that right there, I wanted to remove that. So we'll clean that out. I'll scrub it. So that's just water. I'm going to scrub, get that sealer out of there, rinse it out. I am actually going to let this play because it shows that even experienced operators, this you can fiddle around. So I'm just using my PSR probe because you can use whatever. There's no rules, just to kind of condense the surface. And then let's take a final look here. Right, this is the other hero shot. So these are the mesial canals. So mesiolingual here, mesial buccal, distal lingual, radix, and our distal buccal. There we go. So let's just take a look at our final radiograph here. So here's our final radiograph. Now you can see what are some points. We put a composite restoration in, pretty simple. We're at length especially on our mesial canals. I'm happy with the length on the distal lingual canal or radix. Now it looks more like a trunk. Am I a little bit, I'm actually short on my distal buccal shot. I didn't realize that until I looked at it, post-operatively. Am I happy with this? Yes, I'm confident with it as well because of my apex locator. I'm super grateful you made it all the way to here. If you want to learn any more tips and tricks, check us out at allthingsendo.ca or MB2 Hunter. We've got a couple courses on the go, and they take all of these tips and put them in a modular form so you can work together with us on our Facebook site and accomplish endo. Anyways, thank you so much for joining us. We'll talk to you soon. Cheers. So if we look at the numbers on the apex, on the file, it goes, the little bands on this brand goes 18, 19, 20, and then 22. So what I'm doing is I'm just going to watch wind that file down to length. And because